Good evening, everyone, and welcome to our webinar this evening. It's Local Implementation of Voluntary Assisted Dying. My name is Rebecca. I am a Palliative Care Program Officer at Central and Eastern Sydney Primary Health Network. And with us tonight also is Christina from the events team, and Brendan is also joining us. I would like to start by acknowledging the traditional custodians and sovereign people of the land of which we were working with, and I recognize that, and I'm speaking to you from the land of the Bidjigal people. I recognize their continuing connection to land, water and community, and pay my respects to elders past, present and emerging. I'd like to also extend that respect to Aboriginal colleagues that are joining us this evening. So a few housekeeping things quickly to introduce before I introduce our speakers for tonight. Please note that this webinar will be recorded and will be available on the CESPN YouTube channel in the coming days. At the end of the webinar, the evaluation survey will pop up on your screens. We appreciate your feedback, and if you could please complete this to allow us to issue a certificate of attendance. Also, please ensure that you submit your questions to the Q&A function throughout the presentation. Questions this evening will be taken at the end of the presentation, at the completion of both presentations. To view this box, hover over the toolbar at the bottom of your screen, and there is an option to post anonymously if attendees prefer. So before we get to tonight's presentations, I'd like to mention to the GPs in attendance tonight that Sydney Local Health District are seeking multiple positions for GPs to join their team as a VMO in their voluntary assisted dying program. The links for these job applications are available in these slides. The successful applicants will work as part of the Sydney Local Health District Voluntary Assisted Dying team and will be providing high quality medical care to patients, acting as a voluntary assisted dying coordinating, consulting and administering practitioner under the New South Wales Voluntary Assisted Dying Act. Please note that these applications will close on September 19th. Secondly, I'd like to continue to promote the multidisciplinary outpatient palliative care clinics that are available at St George and Prince of Wales Hospital in South Eastern Sydney Local Health District. These services are primarily an outpatient clinic, but telehealth and home visits are also possible. The service is available to patients who have been diagnosed with a chronic or life-limiting illness and are most likely in the last 12 months of their life. So Prince of Wales will see cancer patients, but St George is for patients with non-malignant conditions. Exciting, there is a third clinic that will be opening in the coming months at Sutherland Hospital as well. Thank you. And lastly, just a quick mention of some upcoming events that CESPN are running, including cultural awareness training on the 18th of October. Completing this training is a requirement of Indigenous Health Incentive and will provide GPs with the opportunity to get 2.5 hours of education activity, 1 hour of reviewing performance and 1 hour of measuring outcomes. And just a couple more events that are coming up that are on your screen there, so please register for any of those that you're interested in attending. We also have a few upcoming CPR workshops. Please note that the one in October has limited spots available. And a final reminder that this evening's event is approved under the RACGP CPD program for 1 hour of educational activity. So that is all for me for this evening. I will now introduce our first speaker for this evening, which is Dr. Belinda Kiely. Dr. Belinda Kiely is a medical oncologist specialising in the management of breast cancer. She's a senior staff specialist at Concord and Campbelltown hospitals. She's the medical lead for the implementation of voluntary assisted dying in Sydney Local Health District. She's also a clinical research fellow at Sydney University of Sydney. Her research interests include breast cancer treatment, survivorship, and helping doctors estimate and explain prognosis to people with advanced cancer. So thank you. Over to you, Belinda.
Thanks, Rebecca. Can you hear me okay?
Yes. Yep.
And I'm just checking you can see my slides as well.
I can see the slides.
Thank you. So thanks for inviting me along to speak this evening. It's a pleasure to talk to you all about this quite important issue of voluntary assisted dying. So as Rebecca said, I'm a medical oncologist and I am working in Sydney Local Health District as the medical lead, preparing for the introduction of voluntary assisted dying. So the Voluntary Assisted Dying Act was passed in New South Wales Parliament in May last year, and it will actually come into New South Wales on the 28th of November, allowing eligible people the choice to access voluntary assisted dying. So that's just over 2 months away. So this is coming quite soon. So if we just look at what is set out in the Act in terms of who is eligible to access voluntary assisted dying, in order to be eligible, a person needs to be an adult, they need to be an Australian citizen and living in New South Wales for at least 12 months. A person needs to have decision-making capacity in relation to voluntary assisted dying, and they need to be acting voluntarily without pressure or duress. A person needs to have a disease, illness, or medical condition that is advanced and progressive and will, on the balance of probabilities, cause their death within 6 months, or if someone has a neurodegenerative disease, it's within 12 months. That's things like motor neuron disease. The person also has to be suffering in a way that cannot be relieved in a way that they consider tolerable. So someone who's suffering and they don't believe that that's tolerable. And the final requirement is that the person is able to make and communicate their request and decision about voluntary assisted dying. So some key points to mention. Only the patient themselves can request voluntary assisted dying. Family members cannot request it on their behalf. A person who has decision-making capacity at the beginning of this process must maintain that decision-making capacity. If they lose their capacity any time along this process, they're no longer eligible. The way they communicate their request has not got to be verbal, so there can be other means of communication used. And just to point out that a diagnosis of dementia or a mental health condition by itself is not enough to make someone eligible for voluntary assisted dying. If someone has another terminal condition and also has a comorbidity of dementia or mental health conditions, they may be eligible, but they do need to meet all the other criteria, including having the capacity to make the decisions. And at present, the way the law in Australia is set up, telehealth cannot be used to discuss the voluntary assisted dying substance or its administration or prescription. So it is limiting a lot of the process and assessments around voluntary assisted dying to face-to-face consultations. Now, New South Wales is going to be the last state in New South Wales to introduce voluntary assisted dying. So we have been able to learn from a lot of the other states who already have similar laws in practice. There will be some differences in New South Wales. So in New South Wales, clinicians will be allowed to initiate discussions about voluntary assisted dying, provided they have this discussion and include information on other treatments and palliative care options available to a patient and the likely outcomes. So as long as voluntary assisted dying is introduced with a set of other options for end-of-life care, doctors can actually initiate the discussion. That's different to the system in Victoria, where doctors are not able to bring it up. In New South Wales, patients will be able to request practitioner-administered voluntary assisted dying, even if they can physically self-administer an oral substance. Again, this is different to Victoria. In Victoria, you can only request practitioner-administered if you can't self-administer. When we look at states and also countries where patients have had a choice of practitioner-administered or self-administered voluntary assisted dying substances, there does seem to be a tendency for patients to choose practitioner-administered. So we are expecting we may see the majority choosing practitioner-administered in New South Wales. And in New South Wales, there's no requirement for the clinicians involved in assessing patients to have expertise in that patient's condition. So we don't need to have oncologists doing this for the patients with cancer. We don't need neurologists involved for the patients with neurological conditions, which is why we're saying that general practitioners, if you are interested in this, it would be great to have you involved. So just a little bit on decision-making capacity. The Act actually assumes a patient has capacity to understand the information. And really what we're just needing is that to be able to, a doctor just needs to be satisfied that the patient is able to understand the information and what the decision means, remember that information, and also to communicate that decision. So similar to how we how we assess people's capacity for other decisions that they are making. You don't need to have a formal assessment of their decision-making capacity unless you've got concerns about it. In terms of what sort of practitioners are eligible to be involved, so medical practitioners can be the coordinating or consulting practitioners. And to be the coordinating consulting practitioner, you need to have either specialist registration or general registration and have practiced for at least 10 years. You must complete mandatory training. You can't be related to a patient that you're actually involved in the voluntary assisted dying process for, and you can't have any sort of benefit financially or materially from the patient's death. The administering practitioners, the people that get involved in administering the substance, again, medical practitioners who are specialists or practitioners who have got general registration and have worked for at least 5 years, overseas trained specialists, but also nurse practitioners can get involved in the administration role. They can't get involved in the consulting or practitioner. And obviously this is all very much an opt-in system. If we just look at what the roles are for the different practitioners, so the coordinating practitioner is really the main person, the largest time requirement. They're involved in coordinating all the steps, so they they take the first request from a patient, and then they work with the patient through the multiple steps. And you can see on the right there's a list of the different forms that need to be completed by the coordinating practitioner for each patient. So there's multiple consultations involved for this practitioner, with an estimate of the time required taking up to a couple of hours over several consultations. Secondly, there's a consulting practitioner. This person only needs to meet the patient once, and they provide their own independent assessment of whether the patient meets the eligibility criteria. So the time requirement here is probably half an hour to an hour, and this requires just that one consultation assessment report form to be completed. And then finally, the administrating practitioners, they're only required if the patient requests practitioner administration. It can be the coordinating or consulting practitioner, or it can be somebody else that the patient or the other practitioners sort of defers to. So the actual process is there's several steps going from the patient making their initial request to the coordinating practitioner, who then does a first assessment of the patient. The patient's then referred to a second doctor to do the consulting assessment. Once the two doctors agree that a patient meets the eligibility criteria, the patient then does a written declaration, putting their request into words, and this request needs to be witnessed by 2 independent witnesses. There's then a final request made, and then the request goes through to the Voluntary Assisted Dying Board, and this is an independent board who will be reviewing all of the requests coming through across the state to see whether the patient meets the eligibility criteria. Once the board is happy that the patient meets the criteria, they then issue a permit to allow the coordinating practitioner to prescribe the substance, which can be oral or intravenous. And then we sort of get then to the substance administration. So you can see this is not a process that's going to be occurring in a single day. It's probably going to take weeks. The shortest time would probably be 1 to 2 weeks for a patient to go through these multiple steps and see the 2 different doctors and get that decision reviewed by the board. This is just showing that same process in a diagram format, so you can see the multiple steps with the board reviewing each patient's application. And there's also a central care navigator service who's going to be supporting patients, practitioners, family members, giving them information and helping to connect people with practitioners in their local area. And that care navigator service is working out of Northern Sydney. So if we just have a little look at the substances that patients will be receiving. So those that choose the oral substance, that can be either self-administered or they can ask for a practitioner-administered oral substance. They will receive a cardboard box, which is the white box there. And within that cardboard box is a black locked box, which is locked with a key, that contains the powder substance that the patient is educated in how to mix that up with a liquid. So there's actually a central pharmacy service that will be delivering this substance to each patient. So it's not going through the local pharmacies or the hospital pharmacies. There's one central pharmacy responsible for delivering this substance. In that box, there are also some adjuvant medications, so antiemetics, anxiolytics, and a disposal tub, because the other important part about this is if patients don't use the substance, it needs to be disposed of. When a patient chooses oral administration and they get access to this oral substance, part of the law requires them to nominate a contact person who is the person who is also then responsible for ensuring the substance is disposed of safely if it's not used. If patients choose practitioner-administered IV substance, this is the IV substance kit, so you can see there's several different medications in this kit. And this is delivered to the administering practitioner. So practitioners that will be doing the administration will be getting this kit from the pharmacy, the central pharmacy again. And again, there are some pre-medications in here. The administering practitioner is given this and then they take it to the patient, whereas the oral substance is delivered directly to the patient. The oral substance has no use by date, so the patients can keep that indefinitely at home, whereas this kit does have a short expiry. If we look at what's happened in some of the other states who have had this voluntary assisted dying in practice for a couple of years now. So Victoria has the longest time, so they've got the largest experience. You can see that the patients requesting voluntary assisted dying, both in Victoria and in Western Australia, were predominantly patients with advanced cancer. 82% in Victoria had cancer, 68% in Western Australia. And the next biggest group are the neurodegenerative conditions, so motor neuron disease, Parkinson's disease, and others. And then it's really that remaining sort of 10 to 15% of people that have other chronic incurable conditions with a life expectancy less than 6 months. So most of the people we will be seeing will be patients with cancer. If we look again at the demographics of the people in Victoria requesting voluntary assisted dying, you can see that the majority are sort of, the median age is 73. Most of them are born in Australia. Most of them speak English. There was very little need for interpreters, but there will be interpreter services available to use for these consultations for patients that do require it. Of note, you can see that 83% of the people in Victoria were already linked in with the local palliative care services. I think that's important. This is not an alternative to palliative care. Most of our patients who are getting end-of-life care in the district will be linked in with palliative care already. This is going to be in addition to that. And I think the other thing that's interesting looking at the Victorian data is that only 2% of people required a formal assessment of their decision-making capacity. So most of them, the doctors were happy that they had the ability to make decisions. Again, just looking at Victoria and Western Australia, you can see just highlighted there, the total number of deaths voluntary assisted dying makes in those states is about 1%. So this is a very small number of the deaths that we're going to be seeing across New South Wales and in our health districts. So we're not expecting very large numbers. If we look at Victoria, the thing that stands out there is that you can see 30% of people died without using the voluntary assisted dying substance. So we recognise there's going to be a group of people that go through this process, get the substance, and then may never use it. They may die before using it. They may choose not to use it. So we'll be expecting a similar sort of pattern in New South Wales. In Victoria, patients have to orally self-administer, which is why most of them are self-administering there. Western Australia, there is a choice of self-administration or practitioner administration, and you can see that over 70% chose practitioner administered. Most of that was occurring in patients' homes, with the rest occurring in public hospitals, aged care facilities. The most common reason in these states for people to be found ineligible for voluntary assisted dying was actually because their prognosis was longer than that 12 or 6 months requirement. So I think the other thing we're going to be having to be prepared for is a lot of people will be asking about this, and we'll have to explain to them why they're not eligible. And one of the big reasons may be that they're expected to live a lot longer than that required time, and maybe voluntary assisted dying is something they could think about and apply for later on in their illness if they wanted to. So in Sydney Local Health District, we're expecting, based on sort of modelling of numbers from other states, we're expecting 150 requests for voluntary assisted dying per year, and about 50 voluntary assisted dying deaths in the district per year. Now, Sydney Local Health District encompasses RPA, Balmain, Canterbury, Lifehouse and Concord. We're expecting most of the people to have advanced cancer, so most of the patients will be coming through Lifehouse and Concord Hospital, where the cancer centres are. For the people with cancer, we're actually hoping that the oncologists will be fitting these assessments into their existing clinics, because these are patients they're seeing regularly very often. But as Rebecca mentioned, we are currently looking for some voluntary assisted dying VMOs to assist with this process in the district, and that will mainly be at RPA and at Concord hospitals with patients with cancer and also those with other diagnoses. Looking at who the practitioners in the other states were, you can see general practitioners have played a big role in Victoria and Western Australia, making up a large number of the practitioners involved. And then there's a bit of a mixture depending on the state of who else was involved, but we'd be hoping to get some passionate general practitioners in Sydney and Southeast Sydney. And just quickly looking at the board. So this board has been established to review all the applications. It will be made up of 5 people. 2 will be legal practitioners, 2 medical practitioners. They won't be employed by New South Wales Health. The central navigation service, as I mentioned, it's going to be running through North Sydney, and this will be available for doctors, patients to contact. It will be a good sort of first point of contact for people, and they will be directing people back to the sort of care coordinators in their local areas. And then there's the central pharmacy service, as I mentioned, who will be responsible for the delivery and disposal of the substance across the state. And just finally, there is going to be education and training. There's general awareness training. That's a 30-minute online training that will be on the New South Wales Health website. It's expected to be available in October. And that's really of interest to anybody, just to get a bit more information. And then anyone who wants to be much more better informed, and particularly those who want to be practitioners, there will be mandatory training, which is going to be taking 6 to 8 hours. It will be available online or in person. And some of the in-person training dates in Sydney, I've just got on the slide here. So 15th of October in St Leonard's, 1st of November Rozelle, 17th of November in Liverpool. So if you are interested in being a practitioner, you are welcome to register for one of those in-person training dates or complete the online training. And I've just got here some places to find out a bit more information. There is the actual Voluntary Assisted Dying Act, which obviously outlines the law in detail if you wanted to read through that. The New South Wales Health website has a lot of information about this already, and that information is increasing. There is going to be an Australian VAD conference in Sydney at the end of September. And following that, there's also a New South Wales VAD implementation conference. So you are welcome to register for either of these conferences. And then, as I mentioned, the mandatory training. And I've just got our voluntary assisted dying Sydney Local Health District email there. But please email us or email me if you are interested, particularly if you're interested in becoming more involved in the actual practitioner process. That's the end of my slide. So I will stop there, and we will be sort of taking some questions at the end.
Lovely. Thank you so much, Belinda. So now we have Dr. Patrick Bolton that's going to speak for us. So I'll just share my screen here.
Thanks, Beck.
No problem.
I'm advised that the quality of my internet is poor.
I'll just quickly introduce you if you like, Patrick. Okay. Sorry. Dr. Patrick Bolton is trained as both a GP and medical administrator and has a long history of working across the hospital and community interface. He is a complex care physician on the Randwick Hospital campus and the medical lead for voluntary assisted dying at Southeast Sydney Local Health District. So thank you, Patrick.
So thanks, Beck. My anxiety is simply that my internet connection may be poor, so please complain if you can't hear me well, and I'll start by darkening my image. Thanks to Belinda. I hope nobody will be surprised to realise that the process that we're running in southeastern Sydney is fairly similar to the process that's running in Sydney because they are both underpinned by the same legislation. Beck, are you going to drive my slides for me, please? Oh, you're muted, but that's okay as long as that was a yes.
Yes, sorry. Can you you can see that slide up there on the screen?
I can't.
Not yet, Rebecca.
I don't know if others can.
No, I can't.
Okay, sorry.
That's just launching now.
Yep, we can see it.
Okay, so there's some aspects that I've sought to emphasise because I think they may be relevant to a general practice audience, but I've sought not to repeat what Belinda has provided. I was interested to hear the numbers for Sydney LHD because we've been told to expect roughly twice as many requests and completions, although the proportion you'll see is much the same. So 300 requests in the first year, of whom about 120 complete. So our model is intended to be a single referral point which will be made available on our internet page, a consulting service that can provide care in inpatient, outpatient and community setting, and our ambition is to link in with the GP around what's happening so long as the participant consents for that. And a service that GPs can engage with selectively at relevant touch points to encourage and support external and usual care so that we get it right. And I'll talk a little bit more about that in a minute. It will be an in-hour service and admissions for VAD will align with existing processes. And the existing processes, we think that VAD will be considered an elective process, which means it will join the queue for a hospital admission on a particular day. And that creates some risk around the certainty of timing. We're still working that through, but I think you all know how hard it is to get into New South Wales hospitals at the moment. And we will evaluate the model in an ongoing way and make changes as we need to. Next slide, please, Beck. So things that you as GPs might want to consider. The first is that on the numbers we have so far, the average GP is going to counter every couple of years. So we think, and I invite you to challenge this assumption, that this means that most GPs will want to know where they can find the info they need when the need arises and won't necessarily want to be experts at it all the time. And we see this as being through health pathways with local referral pathways. There is a statewide health pathway that's being developed by Central Coast PHN, and that will get rolled out across the state with various local modifications. I think Belinda's implied this, but it's important to note that, or in fact, more than implied, has spoken to this, but it's important to note that even conscientious objectors have to provide non-VAD care and provide a notification of the potential participants wish to participate in VAD. There's the rules around residential facilities under the Act, whether the residential facilities support VAD or don't support VAD, is that VAD will be provided in the person's place of residence. So if somebody's in a nursing home which for some reason doesn't support VAD, nevertheless that person will be able to receive VAD in that location. One of the corollaries of that is that the burden of the other care, the non-VAD care, non-VAD care for that person in these settings will continue to fall in GPs, as it does and always has. A distinction between residential facilities and healthcare facilities needs to be made. Healthcare facilities which are non-participant only have to allow the statewide care navigator service in for an initial information sharing assessment. All the subsequent stuff they can say no to. They need to provide, they need to make reasonable efforts to make that available to the person somewhere else, but they don't have to provide it. And that creates some issues, I think, probably more for South East than the Sydney world. But next slide, please, and I'll talk a bit more about it. So there are a number of third schedule services in South East Sydney, and of those, we have been informed that St Vincent's, Calvary and Bolton will be non-participating health facilities. And for South East Sydney, this is important because the hospice for the northern part of South Eastern Sydney is in St Vincent's, and the hospice for the southern part of South Eastern Sydney is at Calvary. So there's a potential considerable overlap about where the services for people who may request VAD are being provided. It's worth noting that our South East Sydney catchment goes to Watsons Bay. Most of you who work in the eastern suburbs will be familiar with the notion that it lists at Moore Park Road over a service-to-service variations, but in this case, South Eastern Sydney goes all the way from south of Port Hacking to the harbour. Those services will do not offer VAD and will continue to provide non-VAD related care. So that creates some potential logistic efforts because a request for VAD from somebody who up to a point in time has received care from one of those hospitals may result in some discontinuity of care, and that will depend very much on the individual circumstances of the participant. We've sought to think this through a bit. We've doubtless more thinking to do about it, but we don't think there's a generic solution to this. It'll be a case-by-case basis. Next slide, please. So we too are keen to hear from GPs who might be interested in working with us as VMOs in this space. And I encourage you to make contact with me if you'd like to do that. We're not as well organised as Sydney. We don't have our ads out yet, but we expect to have them out within a week. So my details are there. I urge you to make a note of them. I'm happy to take a call or take an email at the if you're interested in making contact. And I guess I'd add to what Belinda said, which is to say that I think part of the reason that GPs are the leading practitioners for this is because of the holistic care that GPs provide. My experience of GPs is that they take a patient, their training makes them much better at taking a holistic approach to the patient in their context and their beliefs and value systems. That's not to disparage the specialist view, but GPs' bread and butter is treating people where they are. And so I think that GPs have something to offer here. So while we've been presenting to you, and we're very happy to take questions, a question for you is, what have we overlooked from a GP perspective that we might need to think about? Thank you.
Thank you, Patrick. That was great. So I'll just check. Does anyone have any questions that they would like to ask Dr. Belinda or Dr. Patrick this evening? You could just type them into the chat box for me, and I can answer them for you. No, I won't answer them. I will ask them on your behalf.
It's Brendan here. I thought I might start off with, if you don't mind, which is, tell me about the medical liability issues that some GPs may be concerned about. Would either of you like to comment on the issue around medical liability and how that's covered?
I'm happy for Patrick to take that one, if you like, Patrick.
Yeah.
Okay, sure, thanks. So my recollection is that the Act specifically provides that there isn't liability. Now, clearly the usual requirements for reasonable competence of care apply, but there's not a liability in the sense that that somebody's died at your hands or you killed somebody, and so there's no liability there. The other thing that comes to my question, Brendan, although this may or may not have been your intent, is that there is the possibility for tension to arise, and I advise that it has arisen in other jurisdictions which have more experience with voluntary assisted dying than we do, between the patient and her family. The patient, the recipient of that is the patient, and if he or she is doing something that his spouse or her spouse objects to, we nevertheless have to go ahead with it and manage the spouse, hopefully well, but respond to the spouse.
And I think I'll just add there that the patient doesn't have to tell their family if they're doing this process, which is the other issue which could come up if someone didn't want to let their family know. We're hoping that they will have their families involved in this. I think most people will. But I guess that's the other area that might end up being a bit of a challenge if people are trying to do this and not let their families know. But I think that, this is a process that's been set up in a way that protects the practitioners involved. So you should not be sort of fearing, if that's what you're meaning, Brendan, that you would be sued for going through the process with a patient. It's sort of been set up in a way that there's this is why it's been set up this way. And there's the independent the board that reviews all the applications, making sure that the process is being completed appropriately to prevent that happening. Was there anything more specific, Brendan, you wanted to ask?
Thank you for that. And I can see some more questions coming in the chat. So Rebecca, I'll hand back to you.
Yep, we've got a few questions. And sorry, just to answer, someone mentioned that the chat was disabled. So it is the Q&A box that you have to pop your question into, and then I will read it out on your behalf for the panel to answer. So we have a question just from Gloria. I just want some clarification. If the assessment for the consulting practitioner is so short that you mentioned, Belinda, just the 30 to 60 minutes, what is the evidence they use to make this assessment?
That time is just a guide. So I think it's going to vary, and I think it will be shorter if it's somebody that you know. So I'm expecting, if it's a patient that I've looked after for years with metastatic breast cancer, for example, who decides they want me to be their consulting practitioner, that's going to be a lot quicker for me to do that than it would be for someone who's never met the patient before and has to sort of start from the beginning. So I think that process could take a lot longer depending on how well you do or don't know the patient beforehand. So those timeframes were certainly not meant to be a limit. It was just what's been suggested as the likely time requirement from each of those practitioners, but we recognise it will be more or less. So I think it's just probably making sure that the patient meets the criteria in terms of they're a New South Wales resident, they're an adult, they've got an incurable condition, they've got capacity, they're acting voluntarily, and their prognosis is less than 6 months or less than 12 months. If you're assessing a patient and you don't know what their prognosis is, you can refer them to an oncologist or a neurologist, whoever's involved with their care, just to give you a report of their prognosis. That hasn't got to be a VAD practitioner. So I could give a prognosis assessment for a patient that I wasn't involved in the VAD process for, to someone who was being their coordinating or consulting practitioner. So don't think that if you're going to be one of the practitioners, you need to be able to prognosticate for everybody. You don't. You can get that from their usual specialists. So it really just is making sure that you're happy they're meeting the criteria. There is a form you need to fill out. So we're estimating 30 to 60 minutes for the consulting practitioner only.
Okay, lovely, thank you.
Could I throw in could I throw in, first of all, the timeframes that Belinda has provided are similar to the timeframes that we understand based on the interstate experience. The second is that this is a matter that we've given some thought to because I'm a GP. We are likely to have referrals from St Vincent's where the MRI scan, the PET scan, the tissue diagnosis has all been done by clever doctors at St Vincent's using skills and equipment that they have, and that even where I'd have access to the test results, I could interpret as well as they do. The Act makes it clear that the coordinating clinician and consulting clinician are able to consult with relevant other parties, and because of the way the system works, I guess, for each patient who is requesting VAD, there's likely to be a central consulting physician who's the person, their oncologist or their neurologist. And I've clarified that it is open to the coordinating practitioner and the consulting practitioner to rely on the same advice from the same third-party practitioner. So if Belinda will allow me to imagine for a moment that she's a conscientious objector and I'm seeing a patient of hers, I, as let's say the coordinating practitioner, can write to her and say, "Dear Dr. Kiely, can you please tell me about this person?" And she would write back to me and tell me, and then the coordinating practitioner can use that answer to formulate his or her view about prognosis.
Okay, thank you, Patrick. I have a few more questions. So as a GP, are you able to choose to only play a certain role? For example, a consulting practitioner as opposed to a coordinating, etc. And how would this potentially be organized or coordinated?
So yes, you can sort of participate in any of those 3 different practitioner roles. And I think that I'm imagining, for example, if the majority of the patients are going to be patients with cancer, many of them may have an oncologist who is willing to be the coordinating or consulting practitioner. So it may be that you take on the other role and do it with the oncologist. And that's how that may work. Similarly, if you're going to be an administering practitioner, you don't have to do any of the assessment part. You could just get involved with the administering part. Or you might want to be someone's coordinating and administering practitioner and just get someone like the oncologist to do the consulting. So it's really going to be up to you as the individual how much you want to be involved in. I guess in Sydney Local Health District, we've advertised for VMOs. We'd be hoping for people to be involved in all of those different roles for different patients. But certainly working as a GP, you can choose which you want to do.
There's a bit of a suggestion in my head, which I think I got from the Act, that optimally, the Act thinks, and certainly in my view, optimally the coordinating physician would also be the administering physician. I see it as part of continuity of care, and in a perfect world, I'd see this as part of the sort of cradle to grave care that GPs potentially provide. but I recognise that the overhead in achieving that is quite substantial at the moment.
Okay, thank you. So I have another question. Do GPs need a special cover from their indemnity insurer?
I don't believe so, no.
Will there
No, I
be?
mean, look, I mean, I was just going to say it'll depend on actuarial experience, but there's no reason to believe that GPs who participate in that are going to be any more exposed to medical legal risk than anybody else.
Sorry, Patrick, also your connection is kind of, it's not fantastic. I can still hear most of what you're saying, but yeah, there are moments when it is a bit crackly. We have another question here regarding, they said, will there be any specific templates regarding formalized paperwork?
It's all formalized. So there's going to be a central portal which you register in, and actually you need to register in that if you want to do the mandatory training. That portal has actually just opened now for registration, so people can register. And then within that portal, there are going to be all these forms that you upload and you fill out online. They kind of also auto-populate. So once you've put someone's details in or your details, it does sort of make it a little bit easier by auto-populating. So certainly there are standard forms that will be used for each patient, and that's what the coordinating, consulting and administering practitioner will be using. So it is all very standardized with templates in the portal. So that's where that's sort of the process, that will be the central sort of process for all of the patients requesting VAD.
Patrick, would you like to add anything or move on to the next question?
I'm reluctantly letting Belinda carry the burden, given that my communication may be limited.
Okay, no problem. So another question here is asking, in terms of our medical indemnity, are we automatically covered by them, or is it the indemnity covered by the VAD legislation?
I can't answer that question. Like, I've not been aware of any concerns in other states with people being sued for participating in VAD, because it has been set up in a way to be very safe. I went to a seminar that the medical defence people were running, and they sort of reiterated that fact, that if you're participating in VAD, you're not more likely to be sued. But I can't answer that specific question. I don't know whether, Patrick, you've got anything specific, or Brendan. It's sounding like a lot of the GPs are scared about this issue.
It's not a concern that we've heard for any other jurisdiction. You know, so the experience, I think, it's not reflected in the experience so far.
I think what I would say is there's clearly incredibly well-defined, crafted legislation, and I think that GPs should take confidence in that finely crafted legislation. It's also backed by some truly excellent work that's been done by the New South Wales Ministry of Health. They have been particularly vigilant and diligent in the way in which this has also been constructed operationally. So I think there's a lot of confidence that if GPs act in accordance with the guidance that's been given by the Ministry of Health, I would think that the risks are no more than for many other clinical decisions that GPs have to make.
And I think that, like, each single step has been approved by a team of lawyers that are working closely with the Ministry of Health. So a lot of the delays in getting information out to us is because they are going through it like with a tooth and comb, just to make sure that every sort of all their wording is legally appropriate. So they've been very careful for this very reason. And
can I also stress too the importance of participating in the training? The training is, Belinda, you highlighted the mandatory training. Really encourage GPs to participate as part of that. That is absolutely critical. And the other thing too is it's also possible to dial a friend. We've got some friends in the room. We've got Belinda, we've got Patrick. There are others. So one would think there'll be a network of GPs, medical oncologists that you'll be able to consult with as well. So you're not going to be by yourselves in this. You'll have people to support you during this process if you wish to participate as part of that.
The training as well, you can complete the mandatory training without being a practitioner. So don't think if you do the training you have to be, but I think it's going to be a good way to get educated in the process. And then if you do have one of your patients asking, you then can be involved. So I think I would second what Brendan has said there and say it is a good thing to do. With the VMOs that we're employing in Sydney Local Health District, so if they're working for the district as a VMO, they will actually be covered by our Treasury managed fund for their sort of insurance. So that's another thing to maybe sort of let you all know about. That's for the Sydney Local Health District VMOs, and we are very keen for anyone who's listening to apply for those positions.
Okay, I think we just have 2 questions remaining. So someone's asked, for example, if someone in St. Vincent's Hospital is objecting, does that mean that the oncologist working in the hospital is objecting, or is it that only St. Vincent's Hospital won't allow patients to have VAD as an inpatient there?
All of the above. So that if a healthcare facility decides to be a non-participant, then that trickles down. The Act expressly says that trickles down to their employees. It's not clear from the Act, but I think if those employees work in another institution, they wouldn't be caught at that other institution. If the other institution, if they worked at St. Vincent's and at Prince of Wales, while they're working at Prince of Wales, that'd be okay. But St. Vincent's won't let us. Belinda has said, and I agree with her, that because of the Commonwealth Telecommunications Act, we can't do e-consultations. But St. Vincent's have said that even if e-consultations were supported from that point of view, we wouldn't be able to e-consult with people in St. Vincent's Hospital. So there's a definite there's a definite no, except what is required by.
Yeah. So my understanding. I'm just cutting in there, Patrick, because it was a little bit hard to hear you at the end. But my understanding is that the oncologists seeing patients at St. Vincent's are not able to participate in the VAD assessment of those patients.
Okay. We just had one last question, which I think is referring to why the hospitals are not listed to provide VAD, but I think that has been explained, but I don't know if you want to explain that further, why hospitals are not allowing voluntary assisted dying there.
So I think those particular institutions, it would be religious reasons. So they're Catholic institutions. Yeah. And that's been the case across Australia, that they've opted out of participating in this for religious reasons. I've
gone dark in the hope that it makes me more audible. Yeah, I agree. I don't know that they've expressly. So Calvary and St. Vincent's are both Catholic organisations. Walper is a Jewish faith organisation. I'd contrast that with United War Memorial Hospital, which, as you might gather from the name, is a Uniting Church institution, who are participating in pretty much exactly the same way as public hospitals are.
Okay. Has anyone got any further questions they would like explained?
I've got one further question for both Patrick and Belinda. How will GPs be paid for participating in VAD?
If they're working for Sydney Local Health District, or in general?
In general.
So there's no item number for VAD specifically. So it will just be billing patients as you would normally bill a patient. So you'd be billing them as a complex consultation. I mean, I haven't got sort of expertise in how billing works for GPs specifically, but I know in the hospital, they will just be billed as a new patient or a follow-up patient like we would bill a normal patient. And I think these would be classified as complex consultations. Within Sydney Local Health District, if you worked as one of our VMOs doing this, you would be paid on a sort of sessional hourly rate to participate. So that's how we will be doing it. But yeah, if you're doing it in your own practice, you'd just be billing them as you would other patients.
Thanks, Belinda. Patrick, any other advice?
Yeah, so I would say what Belinda said except insofar as I'd use different words, which I would say even more inadequately than normal by Medicare, because it's going to be time consuming, you know, and even a level D consultation just ain't going to cut it. So which is both Sydney and Southeast Sydney are proposing to pay GPs as VMOs. That's I think it's $270 an hour. It's something of that ilk, which I hope is, if I book you in advance, so you don't have your rooms cost that afternoon. I hope that that's cost competitive for your time, but I'm not imagining that that's particularly. I mean, I don't think it's unattractive, but I don't imagine it's attractive. I don't think you'll be going, oh shit, I want to be a bad practitioner for the money. And I'm hoping that by our doing that, we set a benchmark. I'm advised the Victorians are pushing the Commonwealth to get it remunerated under Medicare, and I'm hoping that if the benchmark is fair, and I'm hoping that what we're paying is fair, that will persuade the Commonwealth to meet that kind of figure.
I think the thing we don't want is to have like just one or two people having to do this for the whole district and getting burnt out. I think this is not going to be an easy job to do. So I think the more people we have involved, the more we can share this amongst us all as a team, it's going to be better, which is why we're hoping to get as many people as possible trained and participating.
We just
want to really echo what Belinda has just said. It's really important that we get a community of practice, a community of practitioners who can support this. So, and I know that there's a tremendous support in the local health districts. There's tremendous support from other leading GPs for those GPs who are interested or are thinking about doing this.
I know that the people who are doing it as practitioners in the other states are actually saying that they find it very rewarding and they actually like the work. So I think people are, as Patrick said, we're not doing this for the money. It's for people who are generally trying to help their patients, and they are finding it quite rewarding.
I'm not sure if we've got time. We have two more questions that just popped up. One is in relation to advocacy and could this occur in relation to the Medicare item numbers, as it's likely to be an important component into the future?
Maybe I could take that one. But in front, yes, there's a lot of advocacy going on behind the scenes on this by the professional colleges, by PHNs, and also by AMA, RACGP as well. I can assure you, there's a lot of advocacy. There's a lot of candle burning going on. People are really trying to get this issue over the line.
And just the last question for this evening. So St Vincent Hospital covers a lot of our cancer patients. So those patients will effectively be refused VAD. If the patient wishes to access VAD, can they then see another oncologist, for example, at Prince of Wales?
Yes, so that's the system we're hoping to put in place. I'm not surprisingly ideologically supported the idea of VAD before I came into the space, and so as I'm getting more into the space, I'm becoming, I guess, more of an advocate for VAD, as you might expect. And this troubles me. It's difficult for me to see how, if somebody gets referred by a GP to St Vincent's with a little bit of rectal bleeding, and there's a natural history that ends up with it being disseminated bowel cancer that's not easily treated, and they opt for VAD. How does that trajectory get optimally managed? Because at some point that person needs to change horses midstream. It's difficult for me, just as a structural issue, to see how that can occur well. Nevertheless, it's not as if, St Vincent's has a big oncology department. It's not as if we can close that down and move it all to Prince of Wales, even if we wished to. So what we're going to need to do is work with St Vincent's and try and make the journey for those patients as good as possible.
So I think they can't refuse, to help patients access coordinators that can help them. So I think we're going to have the central coordinator service, as well as local health districts are going to have these VAD coordinators who can help connect patients with practitioners in their area who are trained and able to help them by being the coordinating and consulting practitioners. So it may not have to be an oncologist at another hospital. It could be that they get connected with a GP in their area, or another specialist in the area who's keen to help them.
And if it's just, bear in mind that even if you're in a non-participant organisation or a conscientious objector, you're still required to provide non-VAD care. So if the person's living in the community, in some ways, I don't think a person who's a patient of St Vincent's Hospital would see very much different to a patient who's a patient of Prince of Wales Hospital. It's only where the patient, because of their physical incapacity, has to be admitted to hospital that there might be the potential need for a transfer of that kind.
Okay. Well, thank you everyone for joining us this evening. Good night.